are here with another exciting episode of What's Up, Dr. Dovec. I am Betsy Dovec, and I am a bariatric surgeon. But today, I'm not talking about bariatric surgery at all. I am having the amazing honor of getting to introduce all of you to, if you don't know him already, his name is Dr. Leroy Schmidt. He is the director of the Joint Replacement Center at GBMC. He is the head honcho, the chief of the division of Orthopedics. And I'm excited to get to know you on a personal level here. There he is, our professional orthopedic surgeon. Hello, Lee, how are you?
Betsy, I'm doing great. Thanks for having me on.
Thank you. So today we are going to spend some time, of course, talking about orthopedic procedures, joint replacements, specifically knee replacements. But before that, as your friend, I want everybody else out there to get to know you on a personal level and what makes you tick and who you are for fun. So thank you so much for filling out your survey. Let's talk about what you like to do for fun here. So I saw that you like to ride fast cars. Can you tell me more about this picture? What is going on here?
So these are called NASCARs, and a couple of us went down and learned how to drive NASCARs around the track. And not in anger, not real racing, but just learning how to control the cars and drive them as fast as we could. It's great fun. I think if I had more talent, I would have been a race driver. But I really enjoy it. It was a lot of fun, and that was a great trip.
Oh my goodness! How fast did you go?
So they would allow you to follow a guy in a pace car, and they would go as fast as you could. So as long as you could stay within 2 car lengths of them, they'd let you go faster and faster, and we got up to about 150 miles an hour.
Oh my goodness, that sounds so fun. Now, I know also you put on there that you also have another hobby, that you like to do something called truck climbing. Now,
Trekking, yeah.
What is this what you're talking about?
Well, that would, no. I go with a group of guys and we do climbing. So like we've climbed Mount Kilimanjaro, we've climbed a bunch of peaks in the Andes, but I don't call it climbing because it's not what the real mountain guys do with ice picks and climbing the mountains. It's just more a hike up the mountains, but they're generally high mountains, 14,000 feet, 15, maybe up to 19,000, which was Kilimanjaro. Where'd you get those pictures?
Hey now, look at you right here. I do my homework when I'm interviewing a guest. So is this what you're talking about?
I had hair.
This is awesome. I mean, you're skiing, you're hiking, you're climbing these mountains. My goodness, you're living your life. You're traveling, you're all over the place. I love this. So did you decide to get into orthopedics because you were falling down mountains too and injuring yourself? Have you ever needed ortho surgery yourself?
Yeah, I have, but that's not how I got into it. I was interested in sciences, but my first year of college, I spent the summer working in shock trauma as kind of an orderly guy up on the floor. And it turned out that summer they were incredibly busy, and the orthopedic team was very short of help. And they came up and they asked for volunteers to come down and help out in the operating room with the orthopedic team. So I volunteered. It sounded like an interesting experience. And I just absolutely had the time of my life. And after spending that summer working in shock trauma with the orthopedic team, I knew what I wanted to do. And because I like to do mechanics as well and work on engines and automobiles, orthopedics was a natural too. So that's when I decided that's what I was going to do. But I fell in love with it then.
Wow. And that you did. I mean, you have an obvious passion for it. We're going to get to see and hear from some of the patients that you have taken care of over the years here shortly. Your patients love you. Your results are some of the best in the country. We're going to go there, which is just exceptional. But, after that summer that you spent there, you didn't start there. You grew up in Riviera Beach. And I want to know more about what life was like there.
Yeah, so Although it looks like it should be spelled Riviera. It's pronounced by those of us who are locals as Riviera Beach. And little small community on the water. And I grew up there, had my own little boat, and I would go out and spend the summers earning money by crabbing, selling the crabs. Uh, it was a pretty lazy little community, but I loved growing up there. It was great.
Wow.
So while I think of me as technically as being from Baltimore, people from Baltimore are quick to tell me that I am not from Baltimore because I didn't go to high school in one of the high schools that are considered Baltimore, so I'm technically an out-of-towner.
I got you. Okay, I'm learning about Maryland every day, people. This is fascinating. So you grew up in Maryland. You're back in Maryland, taking care of the Towson community and doing it well. But you also love to see other aspects of the world. You love to travel. You've been to countless places. Here are some of the highlights of yourself in good old Nashville, Tennessee, with the Grand Ole Opry, and Atlantis in the Bahamas, Niagara Falls. Tell me, what's your favorite place to visit? What was your favorite trip that you've taken?
Yeah, that's a tough question. I have there's one particular town that I liked in the middle of the Black Forest in Germany called Hinterzarten. And if I had to pick one place, that's kind of a magical place. But I like Zermatt in Switzerland. It's another very favorite place that I have. We did a trip to Croatia last year, and I very much enjoyed that. I love the Canadian Rockies, love the national parks. I can't really think of too many trips that I've been on where I didn't absolutely love being there. I love to travel.
Wow. I think that the reason why you're able to give such amazing care to your patients is because you work hard, you play hard, and you enjoy life, and we should all take a page out of that book. And I'm sure these travel restrictions have been tough, but I'm sure you'll be right back out there seeing the world here soon.
We will do our best.
Yes. Let's turn in and talk a little bit about your work at GBMC. I went on your profile on the gbmc.org, and there are almost 400 notes of patient praise for you on there, my friend. Some of them are pretty deep. A patient said, I had hearing loss, and Dr. Schmidt was the only one who carefully looked at me and spoke to me. I felt so comfortable with him. I highly recommend him. He exceeded my expectations. My wife went to him, and then I went to him. He's my favorite doctor. He's a good listener, answers all my questions. It goes on and on and on. I honestly was just too tired to keep posting all these comments. There was just so much praise for you. The community here has known you for years and known your amazing work. So first of all, thank you. Thank you for choosing GBMC to practice medicine. I know that you trained. Tell me a little bit about your training and what it takes to get from medical school, even college, and to become a fellowship-trained orthopedic surgeon.
Sure. So after college, medical school, I went to the University of Maryland and did medical school there. After that, again, because of my love of shock trauma and my thought that that's where I was going to spend my professional life, I did my orthopedic residency at the University of Maryland, and I had planned to be a trauma surgeon. And when I was there in my chief resident year, doing my rotations in shock trauma, again, I absolutely loved it. It was terribly exciting. I spent many a nights there. I didn't come home very much at all. And my wife explained to me at that time that it was wonderful that I had found my passion, but if I was going to do that the rest of my life, wasn't clear whether or not I was going to have time to have children. So I decided at that time that I absolutely loved doing joint replacement surgery as well, and the schedule was much better for one's lifestyle. And so at that point, I decided rather than doing a trauma fellowship, I would do a joint replacement fellowship. And turns out that that was a wonderful decision at that time because I absolutely loved doing joint replacements.
Wow. And I know that you ended up happy ending. You had 2 kids who, can you tell me about them and what they're doing in their lives?
Yeah, so my daughter, who's my oldest, is currently finishing her chief resident year down at MUSC in Charleston, and she is scheduled to start a rheumatology fellowship this summer. And my son is in Palo Alto, and he's doing finance in Palo Alto. So I had one follow in the medical footsteps, and the other decide to make some money. And they'll take care of each other.
They sure will. And you should be so proud. That's amazing. Well, let's talk a little bit more about joint replacements and what that even means for all of us out there, particularly about knee replacements. Now, I know that there's two different types, a partial knee replacement and a total knee replacement. And I do GI surgery, so I'm not really familiar, and I cannot wait to learn a little bit about those today.
Great. So there's actually more than just two types, but that's a great way to divide them up with partial and total. So the reason that we do knee replacement surgery for patients is because they've worn away the cartilage in their knee, generally lost all of the cartilage, the bone is rubbing on the bone, and it has caused patients to have symptoms that significantly impact their activities of daily life despite conservative measures. So once you have failed conservative measures and are having symptoms that are impacting your life, then often joint replacement surgery is what we recommend. Depending upon how much cartilage you've worn away can determine whether or not you're a candidate for a partial knee replacement versus a total knee replacement. Just so happen to have some models to point that out. So first, can you see this here okay?
Yes.
So this is a partial knee replacement. So with a partial knee, we've only replaced one part of the knee. So the knee has three compartments, a medial compartment, a lateral compartment, and then the kneecap that sits on the front. In this case, we've replaced just one compartment of the knee because just the one compartment was worn out. So that's a partial knee replacement. And it's a little bit smaller surgery than a total knee replacement, and the knee feels a little bit more like a normal knee rather than a total knee replacement. And this is an excellent choice for young, active patients. But you need to choose the correct patient, because if you choose a patient for a partial knee replacement and they have arthritis in other compartments of the knee, then they may be at risk for wearing those other compartments out in a short period of time that then becomes symptomatic. And then if that happens, we have to go back in and do a bigger operation, which involves removing the partial replacement and converting it to a total replacement. So when we decide to do a partial knee replacement, we need to be careful to be sure that those are the correct candidates. Total knee replacement, on the other hand, is where we replace all of the surfaces. Now, sometimes people think of a total knee replacement as cutting out the bones completely and putting in a whole new replacement, and that's not a knee replacement at all. With a total knee replacement, it's more putting all brand new surfaces on the ends of the bone. So, for example, on the end of the thigh bone, when we do the surgery, we trim away the damaged surface on the end of the thigh bone and put on the metal cap, the way the dentist would put a cap on a bad tooth. And then on top of the shin bone, we'll go in, we'll trim away the damaged surface, put on the metal tray with the plastic cushion. So instead of the bone rubbing on the bone, it's the metal on the plastic. And then I'll also put a new surface on the existing kneecap so that all of the surfaces in the knee will be replaced. So you can never have arthritis again in the future. Now, because they are artificial parts, it is possible to wear out one of the parts over time. And so we think the most likely part to wear out is the plastic liner in between the two, which is made up of a polyethylene type material. And when I look back at all of my patients, and everyone comes in for follow-ups every 5 years forever, so we follow all of these, we put these into a national registry. These are lasting somewhere around 20 years. That's with technology that's now 20 years old. So we continue to make improvements in the technology. So, for example, I don't know if it shows up well on camera, but the plastic material here has a yellow color compared to the white color that you see over in the partial knee replacement. And the reason it has a yellow color is that one of the failure mechanisms of the plastic or the polyethylene is that it oxidizes and causes late wear and failure of the implant. And so the company has placed vitamin E into the plastic material to scavenge the free radicals. And as a result, we expect that this polyethylene or plastic should last longer than the knees that I did 10, 15 years ago. We won't know that for sure until we follow these another 20, 25 years, but we continue to make improvements and continue to follow our outcomes to make sure that all the improvements that we're doing today are actually improvements. So that's basically the difference between the partial and the total knee replacement.
Wow, so before a patient goes into either having a partial or a total, are there things that the patient can do to really be optimized to make sure that they can make these replacements last even longer and even in the short term have better outcomes and results?
Yeah, Betsy, that's a great point. One of the things that we ask all of our patients to do prior to surgery is what we call prehab. Normally, patients think about rehabilitation following surgery, and that's true. That's the hard work that everyone's asked to do after the surgery's done. But studies have shown that patients that go to physical therapy before their surgery to build up their muscle strength puts them not only in better shape for the surgery, but helps them to speed their recovery afterwards. And occasionally, I'll have a patient that I send for prehab to do their therapy and exercises who works hard, builds up their muscle strength. Sometimes their pain improves to the point where we can put off their replacement surgery longer. So these things certainly are helpful. Also, prior to surgery, all of our patients will see their primary care physician for a full checkup so that all of the medical conditions are optimized prior to surgery. And we have a teaching class that meets prior to surgery where all of the patients that are about to undergo joint replacement surgery attend the teaching class. They meet the team who's going to take care of them in the hospital. The team explains how to prepare for surgery, what happens in the hospital each day, what to expect when they go home. We also have a care coordinator that reaches out to all of our patients prior to surgery to see what their needs are going to be after surgery. Because years ago, knee replacement surgery, everything started once the patients arrived to the hospital. So that arrived to the hospital, we'd do the surgery, and then we'd sit down and plan, okay, now how are you going to do your rehab afterwards? Today, because we're doing some of the surgeries as outpatient surgery, all of the planning is done prior to the surgery. So our care coordinator, when they reach out to the patient, may send out a physical therapist to their house prior to surgery to see how we can optimize their living situation for rehabilitation at home. We see what sort of needs the patient may have after surgery, whether or not we need to have a therapist come to their house, whether we want to take them out to physical therapy afterwards. So we do all of these things prior to surgery to optimize patients before we actually do the surgical procedure, and then it makes the post-op rehab that much easier.
Wow. I mean, you've come a very long way. You sent me some statistic that showed when you used to do joint replacements in the 1980s, patients could expect to stay in the hospital.
I didn't do them in the 1980s.
Well,
That was
not you.
before my time.
In general, please. Of course. No. But surgeons back in the 80s who were doing these were having patients stay for 2 weeks in the hospital. And then when we were doing these operations in the 1990s, a patient could expect to stay 1 full week in the hospital. From 2000 to 2010, you could expect about a 3 to 4 day inpatient hospital stay. And now what you just described, by using prehab, education, setting expectations, having a multidisciplinary team, care coordinators, giving out guides, all of these things have now allowed us to do joint replacements, knee replacements as an outpatient. Okay, so you got to explain this to me. I know that there's 4 different paths to recovery. So explain which path can people be on, and how do I get on the fast track to going right home?
Betsy, I am impressed that you did all of your homework. I really am. So yeah, our 4 paths to recovery. The traditional pathway, as we call it, is patients come into the hospital, we do the surgery, they stay in the hospital for 2 to 3 days and go to a rehab center. And we still have patients that take that pathway. Generally, they're patients that have a lot of medical comorbidities, medical problems, poor home situation, little supported home. And so we still have that pathway probably for 10% of our patients. All the other pathways involve going home. And so those patients that are coming into the hospital, it's an overnight stay, and they go home the day after surgery. Half of those people, when they go home, we send a therapist to their house to work with them at home for a couple of weeks until they go to outpatient therapy. The other half will go directly to outpatient therapy. They don't have a therapist come to the house. And then the fourth pathway, or the no hospital knee as we call it, is for patients that do not come to the hospital to spend the night. They're patients that go home the same day. So these are knee replacements that we do at our outpatient surgery center in Hunt Valley. And so for those patients, for example, if surgery is, let's just say Monday morning at 7:30. So they come in, we do the surgery. Before they leave the surgery center, we make sure that they can walk laps around the center, make sure they can go up and down stairs safely, do all the things they need to do at home. And that 7:30 patient will be home eating lunch at their own house after surgery. And you'd say, all right, how do you do that? Because the big question people have is, aren't I going to have pain after surgery? Don't I need to have narcotics to control the pain? Shouldn't I be in the hospital for that? And that was true 10 years ago. But today, we've, to a large extent, tried to do away with narcotics. And the question is, how do we do that? So when we're going to do a knee replacement, whether it's inpatient or outpatient surgery, we start out by having the anesthesia team do a nerve block where they put some numbing medicine up above the thigh. And it's a long-acting numbing medicine, Exparel. And that nerve block lasts for 2 to 3 days. So patients have pretty good pain relief for 2 to 3 days. So we do the nerve block. I do my surgery. After I finish the surgery, I inject the knee with a cocktail of medications. So between the nerve block and the cocktail, when patients wake up after surgery, they have very little pain. And this is without narcotics. We also use what we call multimodality pain management. So we use a combination of medications, nerve blocks, and so forth to give pain relief. So prior to surgery, we start patients on medicines like Tylenol and Celebrex that are given before the surgery even starts to have those on board. So again, when patients wake up, they have the beneficial effect of those non-narcotic medications. When patients go home, they'll continue with their Tylenol, Celebrex. There's another medication called Tramadol that's a very mild narcotic that we'll give to patients to use on an as-needed basis when the nerve block wears off. We also will give patients oxycodone pills just in case they need it. Some patients need it, some patients don't. But with the combination of the nerve block and the cocktail, this is what allows patients to get up right away, generally without much pain, and not needing a narcotic. One of the big problems that we found patients had in the hospital is that when we would give them narcotics to control their pain, the narcotics had terrible side effects ranging from nausea, vomiting, sleepiness, confusion, all sorts of effects. And so being able to a large extent, eliminate the narcotics is what has made outpatient knee replacement surgery so successful.
Wow. I mean, this is such cutting edge technology that we're so fortunate that you and your colleagues are embracing, that technology has improved, but it's more in the management of these cases that's improved so much with these low narcotics, just Tylenol and injections that last a long time. That this pain can be so minimal that you can be climbing stairs literally within minutes after the surgery and even going home the same day. It's just incredible. So you're obviously very skilled. You've trained all over. You've done hundreds, if not thousands, of these operations. You've done them safely. Your infection rate, again, is almost unheard of. It's so below national averages. Knock on wood, you haven't had issues at all. So I have to ask, on behalf of everyone at GBMC, why do you choose GBMC when you have the option to go anywhere and share your experience? Why Towson, Maryland is where you want to do your practice?
So two thoughts on that. People, always say, why do you have such good outcomes? And I think the reason for that is I just operate on good patients. I think that our patient base that we have here in the area, they're people that are motivated to get well. They're people that follow all the rules and regulations. And I think that we just operate on good patients, and that makes us look good. But I think that the reason that I chose GBMC is that the physicians that surround us here at GBMC, they're all top-rated physicians, and they're patients that I would send my own family members to. And it's really the team here, everyone from the anesthesia team to all of the therapists on the other end that take care of our patients that make us look good. And I love being surrounded by professionals that if I had a question, if I had a concern, or I wanted to send one of my patients to, or a family member, I would send it to one of the people that's part of our community here because they're just excellent physicians. And I'm happy and honored to be able to continue to work with that group of people.
I'll tell you, my friend, you are one of those people. Whenever I have an orthopedic question, whether it be on peds or a joint replacement, you always respond to my texts, my calls. You're so personable yourself, and I'm sure many people out there are thinking, I want this guy to operate on me. I want these kind of outcomes, these kind of results. I want to go right home. I want to get back to my life, and you're just the physician, the surgeon to help them to do that. So I know that you have a new state-of-the-art office to match your new state-of-the-art practice. Tell us more about that overhaul that you guys have recently been able to experience here.
Right. So, we're lucky in that, there's a group of 7 of us now that all have our own areas of expertise. And this big brand new office allows us each to be able to spread out and be able to see all of our patients in the manner in which we can treat them best. So we have, and I'm not going to get into the details about the design, but there's an on-stage, off-stage feature where patients never really have to come back to see the inner workings of the office. All they see is the area where they come in and they're sort of filtered right through from the x-ray department into an office. And the patient flow there has been very nice. And patients that had previously been taken care of at our old office all remark about how much smoother the process is, how easily things flow, how there's much less wait times in the past. And so we're very fortunate to have this beautiful new office, and I'm lucky to be surrounded by a group of partners who can take care of every orthopedic problem that we need to deal with. And being able to do it in a beautiful surrounding is just icing on the cake. And with all of the changes that we've needed to make during the COVID crisis, this office has made that easier as well, enabling us to do the telemedicine and being able to easily social distance and so forth. So it was nice to have this facility when this crisis came up.
Absolutely. And that's great to hear that you are still open during this time. You are practicing safe social distancing practices, following all the guidelines, but most importantly, you're still taking care of our patients. So if I'm out there, I'm having some issues, I really need to have a joint replacement or even just an evaluation, how do I get started with you and your amazing team?
So it's pretty simple. Patients just call the office. There you go. The number's up there on the screen. If you just call the office and you can ask for any one of us by name, and you'll be offered an appointment. And oftentimes, if the physician that you want is not available at the time you want, again, I have partners that can take care of people that have urgent needs that might not be able to wait a couple of weeks to get in to see me for an appointment. So there's always one of us that's available to take care of people for whatever problem that they have. And we have everything at the office that we need to take care of patients. We have on-site x-rays. We have a brace technician who can fit braces in the office. We do all sorts of injections. So it's pretty much full service once you walk in the door.
Well, fantastic. I think if you're out there and you have orthopedic needs, any type, there's probably an expert right here at GBMC's Orthopedic Surgery Department that would be happy to see you. Again, just call 443-849-3838, 3838 to have those needs and questions answered. So Dr. Lee Schmidt, he is the director of the Joint Replacement Center at GBMC. He is the chairman of the Department of Orthopedics. He is the best of the best, and he's right here for you in Towson, Maryland at GBMC Hospital. Lee, thank you so much for telling us about your personal life, sharing a little bit of that, and also for sharing such amazing details about the cutting edge work you're doing in the operating room too.
Betsy, thanks so much for having me. This was a pleasure.
Thank you.